right, good afternoon, everybody, and welcome to today's webinar, Timely Update of Cervical Cancer Screening Guidelines and Prevention Opportunities. My name is Brandy Johns, and I'm the Training and Development Coordinator for the Nevada Primary Care Association. This training is a partnership between Nevada Primary Care Association and the American Cancer Society. I just wanted to take a moment to thank our local American Cancer Society staff partner, June Hunter, Health Systems Manager from the West Region. June will be on the phone to help with moderation and questions. Before we get started, I would like to go over a few items so that you know how to participate in today's event. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your computer desktop in the upper right-hand corner. When you signed in, you may have had the option to listen in using your computer speaker system or the phone. If you'd like to listen in using your phone, just select phone call in the audio pane and the dial-in information will be displayed. Please be sure to enter in your audio PIN followed by the pound sign. During the presentation, please make sure to mute your phone or your computer so that we don't have feedback or background noise. Also, please be sure not to put your phone on hold or we will hear your lovely hold music. You will have opportunities to submit your questions to today's presenter by typing in your question into the chat pane of the control panel. You may send in your question at any time during the presentation. Dr. Sazlo will be answering some of those as she goes, and others will be collected and addressed during the question and answer session at the end of today's presentation. The University of Nevada, Reno School of Medicine designates this live activity for a maximum of 1 AMA PRA Category 1 credit. Debbie Sazlo, PhD, has served as the Director of Breast and Gynecologic Cancer at the American Cancer Society for the past 18 years and currently serves as the Senior Director, HPV-related and women's cancers. Dr. Sazlo is responsible for developing and updating ACS guidelines, including guidelines for breast and cervical cancer screening and for the HPV vaccination. Before joining the Society, Dr. Sazlo was coordinator of the President's National Action Plan on breast cancer. She received her undergraduate degree in biology with honors from Brown University, her PhD in human and molecular genetics from Yale University, and completed a postdoctoral fellowship in the National Cancer Institute's Laboratory of Pathology and Women's Cancers. I would now like to introduce Dr. Sazlo, Director of Cancer Control Intervention for HPV vaccination and women's cancers.
Can you hear me now?
We can, sorry about that.
Okay. Did you hear anything I said? I was talking to myself. So thank you for having me, and I was asked to give you an update on cervical cancer screening, and that's actually very timely because there's some news as of last week that I'll be getting to. So I'm going to quickly go over some basics just for those of you who haven't been living and breathing cervical cancer and HPV every day. I'll give you some of the basic statistics. I'll walk you through the screening guidelines, both from the American Cancer Society and from some of the other organizations that also promote national screening recommendations. I'll talk a little bit about interventions to increase screening rates, and then at the end, I'll talk just briefly about HPV vaccination. So here's just a reminder of where the cervix is. It's also called the womb. And so there are two types of uterine cancer, endometrial cancer and cervical cancer. So we'll just be talking about cervical cancer today. Cervical cancer starts in the lining of the cervix, and it's a very gradual process. So we're talking a couple of decades. There are some cancers that are very fast growing. Cervical cancer is not one of them. Or at least we've identified the progression from normal to cancer that we can see for quite some time before we would get to cancer. So you start on the left of the slide with a normal cervix, which is something that hopefully all women have. And often women, just like most men are get an infection with something called HPV, the human papillomavirus. They're exposed to the virus, is what I was trying to say. And most of the time, you can see by the size of the arrow, that HPV virus and that infection go away on its own. The person never knows they had the virus. There's no symptoms. There's no signs. No problem. Some of the time, that infection leads to some more abnormalities that become something we call precancer. And there are different levels of precancer. So there's, just like there's different stages of cancer, there's different stages of precancer. The earlier precancerous lesions also have this long arrow going right back. So you can have some changes in your cervix. They can be considered precancerous, and they can just go away without ever causing a woman anything to worry about. The higher the level of precancer, the more aggressive it is, the bigger it is, the more worrisome, the less likely it is to regress. But even the most aggressive and most worrisome precancers still have a very high rate of regression, of going away. We just don't know which ones go away and which ones progress to cancer. The longer a woman has the precancer, the more likely it is to progress to cancer. And so that's the difference between precancer and cancer, is the cancerous cells are invasive, whereas the precancerous ones are not. So again, very gradual process. In this country, because we screen most women, and in other countries, other high-income countries where they offer cervical cancer screening, the number of cervical cancer diagnoses and the number of women who die of cervical cancer is relatively small. So in this country, we have between 11,000 and 13,000 women diagnosed every year, and about 4,000 women die of cervical cancer every year. That does not tell you the whole story, because screening finds those precancerous lesions in over 1 million women every year. And about 1/3 women every year have these high-grade precancerous lesions. So that's what we're finding most often. That's what we're treating, removing, curing. And so if it wasn't for screening, we wouldn't have these numbers. And on the right side, you see that most of the world, particularly the low and middle income countries, do not have screening or only screen a tiny fraction of women. And because of that, the number of women diagnosed in the world is over 500 million women every year. I'm sorry, half a million. And over 250,000 women die of cervical cancer every year. So it's a much more fatal, dangerous issue in countries that don't have screening, which is most of the world. So I mentioned the infection of the cervix is with this HPV virus, or human papillomavirus. And virtually all cervical cancers are caused by HPV. In the literature, in the scientific literature, up to 10% of cervical cancers, it has been said, are not caused by HPV. That 10% or so is a combination of laboratory error. So really there is HPV and the laboratory didn't detect it. There are some very rare types of cervical cancer that are not caused by HPV. Again, the vast majority, upper 90%, are caused by HPV. There's also some cancers that are diagnosed as cervical cancer that are actually misdiagnosed. They're either a recurrence of another cancer from another type of the body or a different uterine cancer. But for our purposes and the types of cervical cancer that we screen for, these are caused by HPV. So what is this HPV? There are about 150 types of HPV, of which 15 can cause cancer. They can cause cancer of the cervix, of the vagina, of the vulva, of the anus, and also of the throat. These viruses are so common. About 90% of the world's population and the US population, both men and women, will have an HPV infection at some point in our lives. So probably everybody on this webinar has either had an HPV infection or will get one before you die. But almost all of the time, those viruses go away on their own, and so it's nothing to worry about. Sometimes the HPV sticks around and can cause cancer. Can we prevent this? Yes. So I mentioned screening often detects the precancers, and so if you treat or remove the precancer, you have prevented cervical cancer. And then, as I'll mention briefly at the end of this talk, there's an HPV vaccine that also prevents 90% of cervical cancers. Screening. So what do we recommend? These are our recommendations all summed up very briefly. Start screening at 21. Don't screen before 21. In the 20s, use the Pap test every 3 years. Once a woman reaches 30, HPV plus Pap together is currently the preferred approach, and I'm going to show you data that HPV plus Pap every 5 years is at least as safe as a Pap test every year. So if you're old school and you remember when women came in every single year for their Pap test, it is perfectly safe to not get a Pap test every year. It's actually harmful to get a Pap test every year, and I'll show you the data on why that's true. Women who have been screened regularly and have been getting normal results should stop screening after the age of 65. Women who've had a hysterectomy don't have a cervix. 99% of the time, a hysterectomy removes the cervix. You don't screen for cervical cancer in a woman who doesn't have a cervix. Yet, 15 million women every year who don't have a cervix continue to get screened for cervical cancer. And for right now, we still recommend that if a young woman comes in for screening and she has been vaccinated, she should follow the same recommendations as a woman who has not been vaccinated. And I'll go into a little bit more detail about what we know about that as well. So again, no annual PAPs, and the only exceptions to these guidelines are if a woman has had cervical cancer. Most of the time, if you've had any cancer, you have different guidelines that are for high risk, at least for a period of time after your cancer diagnosis and treatment. Decades ago, there was a drug, DES, that women often took when they were pregnant. It prevented morning sickness, and unfortunately, it caused some rare types of cancer. And so women whose mother took DES, and these women are pretty much aging out of the system, but for those women whose mothers took DES while they were pregnant with them, they have separate high-risk guidelines. And similarly, women who have a weak immune system, including women who are HIV positive, women who have been on chemo that suppresses the immune system, women who are taking drugs because of an organ transplantation, these women would be screened more aggressively as well. But everybody else can follow the guidelines. So old school, talking 15 plus years ago, we said if you started having sex early, you should start getting screened earlier. If you have a history of multiple sexual partners, these women should not follow any different screening recommendations. That was changed more than 15 years ago. Now, when you have two tests that you can do for screening, an HPV test and a Pap test together, you then are faced with 4 different results instead of 2. Instead of just positive or negative, you have positive, positive, negative, negative, and positive on one, negative on the other. And so in our last guideline, which is from 2012, updated in 2015, we included this gray area of what if you're positive, negative, or negative, positive. If you're positive, positive, you go follow other guidelines from another organization, the ASCCP, because the American Cancer Society is focused on screening. once you have an abnormal screening test, we refer you to the specialty provider organizations who give guidelines for what to do next. But this is a gray area for us, and we didn't want to lose women. So we collaborated with the ASCCP as well as others to come up with these recommendations. And it's a little bit more advanced than screening, so I'm not going to go into the details, but I just want the participants today to be aware that we have guidelines for these women and different options, and that, that these were considered. So 25 is the number of organizations that participated on and endorsed these guidelines. That's a lot of organizations, and pretty much every national organization who has anything to do with cervical cancer screening in the US, and included some from Canada and I think also the UK. So this had wide consensus. So my next several slides are going to talk about what's the data that got us to these recommendations. So when to start screening. And this recommendation was one of the fastest recommendations to be adopted by the medical profession probably in history. A lot of times you put something out there and people take years to follow it. They don't quite believe it. They still believe what they want to do is best. But by the time we updated the guideline and when to start, it was pretty clear, particularly to gynecologists, that we were way over screening teenage girls and women at age 20, finding a lot of stuff that was never going to cause any harm, and following it up and following it up. Because once you find something, it's really hard to say, oh, let's just watch and wait and see what happens. And that creates anxiety for people. It creates concern of what if this woman doesn't come back. So don't screen before age 21. And here are some reasons. One, cancer is very rare, even for women in their early 20s. We're talking less than 1 in a million. And that 1 in a million case, while very real, and while we would love to prevent that cancer, screening wasn't finding it. It may be that they had some very rare type of cancer, some very aggressive cancer, but rates of cancer in populations that screen before 21 are no different than rates of cancer in this age group in other comparable countries. So even if you want to try to prevent that cancer, screening is not the way to go. And finally, as I alluded to, these women get a lot of HPV infections. It's a very common age, and it causes some changes in the cervix that are not worrisome, but that lead to additional procedures, again, because people don't want to take a chance of waiting and watching. So it's actually harmful to be screening these young women. Next, we looked at how often do you screen once you start? And this is where we not only followed our previous guidelines that go back a number of years, and I think it dates back to 1980. So that's almost 40 years, where we and others have said women don't need to be screened annually. In 2012, we and the 25 organizations we were working with went from it's not recommended to we recommend against this. Do not screen annually for any reason unless these women fit into those high-risk categories that I mentioned in the beginning. There's no evidence to support it. There is evidence that it increases harms. There is evidence that it's not beneficial. So why would you do something that has no benefit and does have harm? The only reason, there are a couple reasons I will tell you are out there. One is women don't believe us, and they think that we make guidelines that are influenced by saving money, which is not true, because money and cost was not a factor in our guidelines or any of the other guidelines out there. The second reason is the gynecologists or other providers either think women want it and will go find another doctor if they don't get it, or they think that the only reason women are going to come in to for their appointments for other purposes is to get a Pap test. So when I was growing up and in my 20s, I had to get a Pap test every year in order to get a refill of my oral contraceptive prescription. So that was what was being done. They held us hostage. And I still go into a gynecologist for an appointment, and the nurse and doctor say to me, now, it's really important, Ms. Zaslow, for you to come back in a year for your annual visit and your annual Pap test. And I look at them and I say, and why should I do that? So absolutely, women can go every year for a medical appointment. And I would argue that a whole lot of women would be very happy to go to their provider more regularly if they didn't have to have a Pap test, because we don't really enjoy getting a Pap test. So why not screen annually? Most abnormal screens represent this transient HPV infection. It's not harmful, it's not going to lead to cancer, but it's enough to raise a signal on the screening test that a lot of providers won't want to ignore. And so we looked at cancer risk over different time periods and showed how many women would be harmed compared to how many women might be helped. And the numbers are just really against frequent screening. So the risk of cancer in less than 3 years after a negative Pap test is almost the same as the risk after 1 year. And I have a little bit more data to show you on this. Now, what's all this talk about harms? What's the harm of doing an extra Pap test or two? So it's difficult to measure harms because harms don't always get reported in the literature, so it's difficult to count them, to collect and show the evidence of them. So what we did is, and when I say we, I mean a guideline panel of 100 experts that got together to do this. What we did is we said, if a woman has a positive Pap test, what happens to her? Chances are the provider says, come back and I'm going to do an exam called a colposcopy, which is basically looking at the cervix with a microscope, with a probe that magnifies what they're looking at. And a colposcopy is not pleasant. It takes some time off from work. It's not cheap. It's not overly expensive. But the colposcopy is the first test that leads to everything else. So if a woman is going to have a more serious harm from screening, it's going to have led from the colpo. So the colpo, you look and you say, oh, I see an area that's a little suspicious, so I'm going to do a biopsy. So that's more invasive than just looking. The biopsy I'm not sure about, so Mrs. Jane Doe, I want you to come back in 6 months and I'm going to look again and I might do another biopsy. And suddenly you're weakening the cervix. So these women who have abnormal Pap tests tend to get stuck in a revolving door of going back for more procedures that often get increasingly invasive. And so the colposcopy itself is not particularly harmful, but it leads to more aggressive and more potentially harmful side effects. Colposcopy is also the measure that is most likely to be reported, and so we could count them. And so here you see that coming annually for a Pap test has almost 3 times as many procedures as coming every 3 years, and that's 2 colpos per woman. So you're talking about a lifetime risk of having to have these colposcopies for pretty much every woman out there. So the recommendation for these women in their 20s is get a Pap test every 3 years. This maximizes benefit and minimizes harm. Once a woman turns 30, we recommend that she also get tested with the HPV test. So that's called co-testing, testing with both the Pap and the HPV test. She could keep testing with the Pap test alone, that's also called cytology, every 3 years. but it's better to add the HPV test. And the reason is that if you add the HPV test, you're going to detect advanced precancers, this is CIN3, earlier than just using a Pap test. You can lengthen the screening interval, which again, women don't particularly enjoy putting their legs up in stirrups and having instruments, inserted into them. So a lot of women would prefer a 5-year test over a 3-year test, particularly if she's confident that it's safe. Also, I mentioned that there are different types of cervical cancer and that cervical cancer screening detects the most common types. There are 2 of these, and one of them is adenocarcinoma, which is somewhere around 20 or 30% of all cervical cancers. The Pap test is not very good at detecting these, and so HPV testing adds this benefit. Now, I'm going to come back to this fact later, so I'm just going to tell you that the benefit of co-testing comes mostly from the HPV test. Once you test with HPV, the Pap test adds very little to it. So I'm going to come back to that. So why do we say co-testing is better than Pap testing? And I'll mention that the U.S. Preventive Services Task Force is the other main group in the U.S. that does screening guidelines. And their guidelines are exactly the same as the American Cancer Society with one difference, and it's this word prefer. So we say we suggest co-testing is the preferred approach, and they just say women have these 2 options. But we looked at the data from the studies available at the time, and we found that even 6-year testing is going to decrease your risk of advanced precancer by more than 3 years of Pap testing. So this is your benefit. You are detecting more advanced precancers, which is really what we want screening to do. We want it to detect the precancers before they progress to cancer. So here's a little bit of data, and if you look at the first line that's going all the way up to the top of the page, that's your Pap alone. And if you look at the first time, which is 12 months, that's your every year Pap. And so every year Pap is the start of that lowest blue arrow. And if you take that all the way across, the red and green lines don't approach that it looks like around the 20%, 20 per 10,000 incidents until you get out to 60 months, which is 5 years. So that means that the red line, which is HPV testing alone, and the green line, which is co-testing, have the same risk at 5 years as a Pap does at 1 year. And we don't even recommend the Pap until 3 years. So look how much safer it is to get a Pap plus HPV or HPV alone at 5 years than a Pap test at the recommended 3 years or at the old recommendation of 1 year, old meaning 40 years ago. So we looked at so much evidence. I think there were 12,000 articles that we reviewed. And of course, we didn't review every single one, but that's how much we found at the first stage of our literature review. And we found a lot of large studies showing the additional benefit and actually less harms of using the HPV test in addition to the Pap at the longer screening interval. So this is really supported by very convincing evidence. In addition to the large studies done in many countries in Europe, a couple places in Canada, and a large observational study in California, we also had modeling studies that also showed the harms of screening too often. And we have studies showing lack of benefit of screening the teens, the under 21. And at the time, we had some evidence, like what I just showed you with one, I can't remember if it was the red or the green line, of HPV testing alone. And I'm going to come back to that in the next slide or two. and also emerging evidence of screening after vaccination, which I'll also come back to in a minute. So what are your take-home messages from all this? Well, all of this data is on women who get screened, but who's the most likely to get cancer and die from cervical cancer? Women who've never been screened. So if you're out there in a clinic or you're an ACS staff or public health staff person, your effort should be on the 20 to 30% of women who just don't get screened. Maybe they've never been screened, which is about half of all women who die from cervical cancer, or maybe they haven't been screened in over 5 years, which is another 10% or so of cervical cancers. Another take-home message is for those 75% or so women, that's a national number, it might be a lot lower in some of the clinics, but for those women who are getting screened, a lot of them are getting screened too often. They still have that, I need the annual PAP, or even if I'm adding HPV, I still need to get screened as often. They still have that in the back of their head, or their providers are thinking, I need to see this woman and the only way I can get her in is if I, get her in for the PAP test. Screening with HPV plus PAP is best, and the little asterisk is that evolving evidence for HPV alone, because HPV alone really provides most of the benefit. The 5-year interval is very safe when you have that HPV test, and as I mentioned, a lot of consensus on this and really strong, rigorous evidence review. So I've mentioned a few times HPV testing alone, and that's called primary HPV screening. And I'm going to compare that a little bit to co-testing, because the question out there now is, do we really need the PAP test, or do we really need the PAP test with the HPV test, or can we just have the HPV test alone? And the American Cancer Society reviewed this in 2015, which is when the FDA approved the first HPV test to be used alone for screening. Now there are four HPV tests plus one HPV test that is just a couple of types of HPV, but 4 that can be used for screening with the PAP test as co-testing that are approved in the US. One of these went for FDA approval to be used alone. You may be aware that it's very expensive to do the types of clinical studies that the FDA requires, and it takes years or even decades to get the evidence. So some of the other manufacturers of HPV tests just didn't want to put the time and money into doing that. I am told that one of the other remaining manufacturers of an HPV test that's approved here, it is either has submitted their data to the FDA or is very close to doing that. But I think we're at least a year and maybe up to 3 years away from having the second company considered by FDA. For that first one, the FDA looked at the evidence and said, you need some sort of follow-up. If you have just the HPV alone, what are you going to do next, depending on the results? So again, you're either positive or you're negative. If you're negative, which is the bottom, just go to routine screening. And in this case, this company only followed the women in their study for 3 years. So they could only ask the FDA for a 3-year screening interval. So that's what routine screening is for this HPV alone test. This test tells you which types of HPV the woman had. If they have types 16 or 18, those are the 2 types that cause 70% of cancer, cervical cancer, and are the most aggressive. So if a woman is positive for these 2 types, they go straight to colposcopy. There are 12 other types that cause cancer in this test, and I think they're all bundled up. I don't think they're broken down 1 through 12. If a woman has any of these other types that are not as aggressive, then they get a pap test. So instead of pap with HPV or pap followed by HPV, they have HPV followed by pap. And then there's an algorithm to follow up. When the ACS looked at this, we said, you know, there are a lot of unanswered questions here. Shouldn't the interval be 5 years? But you can't do 5 years because we don't have the data yet. And when do you start this? Because the FDA approved it starting at age 25, but previously all organizations said to don't start HPV testing until you're 30. So the ACS said, we don't have a recommendation either way, but if providers want to do HPV testing alone without the pap test, they should follow these other interim guidelines put out there by a consensus group of experts and organizations. So that's where we are with primary testing until last week. Last week, the U.S. Preventive Services Task Force put their draft recommendations out for public comment. Now, it's really difficult to comment to you on draft recommendations because they're only draft, and who knows what the final will look like. So I'll just tell you what the draft says. It says, all the recommendations are the same as everything I just presented to you from 2012, except that instead of co-testing, the task force is saying we should switch to HPV alone. Still every 5 years, everything else is the same, but they don't comment on, and what do you do if the woman's positive? If they're negative, they go every 5 years. So bottom line is their draft says replace co-testing with HPV testing alone or primary screening. And we'll see over the next couple of months what happens. And so we, at least I, have a whole bunch of questions about this. One is, which test? I mean, the task force draft recommendations and their evidence reviews said absolutely nothing about the fact that one of the tests has FDA approval and the others don't. And while there are a lot of similarities between the 4 tests, there are some differences that could be very important when you talk about using them without a pap test. Next, only one of the tests is FDA approved. So I guess the task force is saying that it's okay to use the other tests, quote, off-label. And finally, what do you do with the woman who tests positive? Presumably, they would just follow the algorithm that was approved by FDA for that one test, but that's for a 3-year interval. So there are some gaps in what the task force put out there as their draft. Another question that we're starting to look at more, and the task force did not look at this, is when is it going to be time to change screening? Because so many girls are being vaccinated now and are entering the screening population. So the vaccine has now been out there for 10 years in this country and recommended at age 11 and 12. So if you were a girl at age 11 and got vaccinated the first year that the vaccine came out, or maybe you got it at age 13 or 14, you are now in your early 20s and you're coming in for screening. We know from a lot of data that those girls, first of all, the pap test is not very helpful for a vaccinated population. Second of all, most of these people are not going to have an abnormal screening test worth detecting. So we're going to increase our number of false positives. And the whole point of vaccinating is so that you can either screen less or start later. So there are some experts that are really raising the question, and I expect will comment to the task force. It might be time to start thinking about starting later, maybe at 25 instead of 21. Maybe we start at 25 with the HPV test and just skip the pap test completely. And that's exactly what Australia is doing now. The vaccine has been so much more effective than our wildest dreams could have predicted. The herd immunity, the protection of those that get vaccinated that they confer on those that don't get vaccinated, the protection from 1 or 2 doses, well, now it's a 2-dose schedule, but before it was 3 doses, that protection is so high that some people think we're going to be able to change our screening guidelines a lot sooner than expected. So I'm going to change gears a little bit to interventions. There are similar challenges and opportunities for screening and vaccination, regardless of what type of cancer screening you're talking about, whether it's cervical, breast, colorectal. Number one always is provider recommendation. Ask any person why they didn't get screened for breast cancer, cervical cancer, or colorectal cancer, or why they didn't vaccinate their child, and they will say, my provider didn't recommend it. Sometimes the provider said, oh, yes, I did, but they didn't recommend it in a way that was effective. So somehow the patient didn't understand that that's what the provider was doing. Regular source of health care, opportunities such as checkups, reminder systems, having a medical home, having shared and informed decision making, and having quality assurance are all challenges and opportunities for better screening and better cervical cancer prevention. So if nothing else, if you want to focus your interventions efforts on something, the ones with the most evidence, the biggest bang for the buck, are reminder systems, increasing access, any intervention in the healthcare setting as opposed to in a school or in a community group or in a health fair, and doing 2 or more interventions is going to give you exponential increased impact compared to, it's sort of the 1 + 1 = 3. Doing multiple ones is much better than doing just one. All right, so switching gears again and introducing the concept of vaccination. This pyramid shows you the 4,000 cervical deaths. It's a little bit old, so it has the 11,000 new cases of cervical cancer. It has that 1/3 cases of high-grade precancer. It also has 1 million new cases of female-only genital warts. This slide is just females. And the additional low-grade precancers. All of that is millions of women and billions of dollars. Now take a close look at the shape of this pyramid, because in the next slide I'm going to show you what this pyramid will look like when we increase our vaccination rates. So I hope this convinces you that we should be vaccinating all of our girls as well as boys. We will reduce cervical cancer, we'll reduce precancers, we'll reduce genital warts, we'll reduce these low-level abnormalities that still are costly and stigmatizing and anxiety-provoking. So, yes, we have a vaccine to prevent cancer. It's the second vaccine that we have to prevent cancer. The first one is the hepatitis B, but a lot of people didn't associate that with cancer prevention. It was more just, preventing a liver disease. So we can prevent cancer. We can prevent 6 types of cancers. It's safe. It's extremely safe. It's extremely effective. We have a ton of data on safety and effectiveness, but we're not using it enough. We're not vaccinating enough of our kids. And we know that we can do better. And the reason we know this is because the vaccine is recommended at age 11 and 12, at the same age that Tdap and meningococcal vaccines are recommended. And 80 to 90% of kids are getting those 2 vaccines, when only 60% of kids are getting the first dose of HPV and maybe 40% are getting the second dose. So these are not anti-vaccine parents. These are not kids and parents who just don't come to the doctor's office or don't have access or don't believe in prevention or vaccines. These are kids that are coming in to the doctor's office or the clinic or the public health building, whatever, and they are getting these other 2 vaccines. So we know that all we have to do is get that 3rd vaccine into them. And we know how to do this, and a lot of organizations are working really hard to try to get what we know out there and to get people to actually do this. And what's really problematic is that cervical cancer has a lot of disparities. It's highest in certain populations, in certain regions of the country, in certain demographics and income. And it's the same people where these cancer rates are the highest, where we have low vaccination rates. So where we have an opportunity to eliminate disparities, which is what happened with the hepatitis B vaccine, but instead we're on track to make the disparities even worse. So we've got a lot of work to do. So what's the vaccine recommendation? Vaccinate boys and girls. Vaccinate at 11 to 12. That's the recommended age. We call that on time. You can start at 9 or 10. And a lot of providers have been reporting, mostly anecdotally, but we're starting to collect the evidence, that they have a lot better success at vaccinating at the younger age. The parents seem more open to it. And also some parents just don't want to give their kids 3 vaccines in one visit. So instead of what's happening, which is they come back a year or two later or not at all, to spread it out, if you start at 9 and give the second dose at 10, you're done. You can vaccinate from ages 13 to 26. If you don't get that first dose in by age 15, you have to give 3 doses. And who wants an extra shot and an extra visit to the doctor's office? So that's an added incentive to do it on time or just a little bit late. And what the American Cancer Society has been saying is if you get young adults in a doctor's office or in a public health facility who haven't been vaccinated, go ahead and vaccinate them, but let them know that it's less effective. And if you are a public health person or you are looking at a quality improvement effort in your practice, focus on the on time, because you only have so much effort. If you can do an intervention that targets 9 through 26, great, do it. But if your resources are strapped, focus on the 11 and 12-year-olds or the 9 to 12-year-olds or the 9 to 13-year-olds, because every year that vaccination is delayed, the cancer risk goes up, the effectiveness goes down. So the evidence-based strategies are pretty similar to for screening. Reminder and recall, standing orders, provider and assessment and feedbacks, that's our government AFIX program, and use your immunization information systems, use your registries in your state. The reminder recall can be at the provider level and or at the parent or patient. Both is great. And hopefully I've left some time for some questions if you want to add them to the chat box.
I'm not quite sure if Wendy means, you know, once someone has declined, if there's information to change their mind or what. So Wendy, if you'd like to come off mute and ask Dr. Saslow directly, please feel free to. Or if not, Dr. Saslow, maybe you could provide some guidance on that.
Yeah, so that's a tough question. I've been very involved in our guidelines and not so involved in our interventions lately. ACS had a program way back called Tell a Friend, which was to tell a friend to get breast screening or cervical screening, and we did have this whole Q&A. If you reach out to someone and they say no, what do you do? And I'm sure that information is available somewhere and we would have to dig it out. And we may not have to dig it out. Maybe it's readily available on either cancer.org or somewhere else.
Perfect, thank you.
The HPV test is done the exact same way and at the same time as the Pap test. So Pap test used to be you do a swab of the cervix and you smear it on a slide, a microscope slide, and that's why it used to be called the Pap smear. And then about 15 years ago or 20 years ago, we switched to a liquid Pap. So you take that sample and you dunk the cells into a liquid, and you use the same liquid, the same sample for the HPV or the PAP test. So if you're just going to do the HPV and not the PAP, you would use that same liquid sample.
Still have a couple of minutes available if anyone else have any other questions. You know what came to mind, Dr. Saslow, when you were talking about the screening guidelines and over-screening? Now I'm wondering, with our state-funded federal program, with our federally funded state programs for breast and cervical screening across the country, what recommendations are they using? Do you know?
Yeah, I'm almost positive that the breast and cervical program follows the same guidelines because the government was in on it. You know, they were one of the 25 organizations.
Okay.
And they usually follow the task force, which, you know, may change now, but until now it was the same.
Okay, good. All right, thank you. And yes, the slide deck will be available following the webinar today, and you should be able to print that out. Right, Brandy?
Yes, we can provide that in our follow-up.
Awesome, thank you. Any last?
Thank you. Sorry, go ahead.
Sorry about that. Just, you know, an opportunity. Any last questions here? We've got just a couple minutes left, and I think we're all clear for now.
Okay, I'll try to find that information on what to say to a woman who refuses screening, and if I can find it, I'll send it to June to send out to everybody.
Perfect. Thank you, Dr. Saslow.
Thank you.
Go ahead, Brandy.
Well, thank you, Dr. Saslow, and thank you to everyone for attending today's webinar. If you have any further questions, please contact us. Our contact information is on the screen right now. Once you leave today's webinar, you'll receive a survey on the presentation, and we'd appreciate if you complete that and provide your feedback. It is required for the CEU credit. You will also be receiving a follow-up email within 24 to 48 hours with a link to the recording of today's webinar. And on behalf of Nevada Primary Care Association, the American Cancer Society, and our presenter, Dr. Saslow, thank you for joining us today, and have a great rest of your day.
Thanks, everyone.